I would like to briefly introduce our speakers for today. So Dr. Kevin Shield is an independent scientist at the Institute for Mental Health Policy Research and head of the World Health Organization, Pan-American Health Organization, Collaborating Center in Addiction and Mental Health at CAMH. He's also an assistant professor in the epidemiology division of the Dalai Lama School of Public Health at the University of Toronto. Dr. Shield's multidisciplinary public health surveillance research programs generate scientific data that inform individuals, clinicians, and policymakers on how best to reduce the public health harms caused by alcohol and other drugs. He's a member of the low-risk alcohol drinking guidelines scientific expert panel that developed the guidance that we're talking about today. Dr. Peter Butt is a certificate and fellow of the College of Family Physicians of Canada with special competency in addiction medicine. He is clinical associate professor in the Department of Family Medicine at the University of Saskatchewan and served as consultant in addiction medicine in the Saskatchewan Health Authority. His research is focused on guidelines and knowledge translation, with committee work dedicated to improving care systems for people with substance use disorders. He chaired the original development of Canada's low-risk drinking guidelines, which was 2011, and chaired an update with CCSA. Our third speaker, Helis, is a knowledge broker at the Canadian Centre on Substance Use and Addiction, co-leading the knowledge mobilization activities related to the guidance. Since 2014, she's led knowledge translation strategies of large-scale health research projects, particularly in the areas of mental health, as well as chronic and infectious diseases. She has a strong interest in clear communication and in meaningful engagement with partners to support understanding and use of research evidence in healthcare decisions. And finally, our moderator today, Bryce, is a senior knowledge broker at CCSA. He's worked on various alcohol and workplace-related projects at that organization, focusing on policies, practices, and programs. Bryce holds a degree in psychology from the University of Guelph and an MA and PhD in human kinetics from the University of Ottawa. Those are our four presenters today. I will now hand over to Dr. Kevin Shield to get us started.
So overall, I just want to talk about the guidelines and what they do and what they don't to start, and then more about the intricacy of the guidelines and some misconceptions about the guidelines. So overall, what the guidelines do is they provide risk information. So you have people at no risk, low risk, moderate risk, and then increasingly high risk. And we provide the public with the risk zones based on their average alcohol consumption. And that's part of the guidelines. Next slide. But that's not just what we do, part of the guidelines. The guidelines actually give advice on when you should drink and when you shouldn't drink. So if you're pregnant or breastfeeding, it's best not to drink. Breastfeeding, there is that exception when you would engage in what is colloquially termed pump and dump, because alcohol can be metabolized and isn't found in breast milk after a certain amount of time. But it also talks about intoxication as well. So you shouldn't exceed 2 drinks on any day. And this is mainly due to the intoxicating effects of alcohol and the impact on injuries. But overall, the guidance is for risk communication and reflection on a person's alcohol consumption, other than the per occasion drinking and the people who should not consume alcohol or should limit their alcohol use. The guidance isn't recommendations, it's guidance. So we're informing you about the risk, and we are promoting reflection upon your risk. But we're not telling you to drink 1 to 2 drinks a week. We're not telling you to drink 2 to 6 drinks a week, and we're not telling you to drink 6+ a week. What we're informing you about through the guidance is your risk. Next slide. So what have been the media reactions to the guidance? Well, mostly in fact, it's actually been positive. So Catherine Parody did a content analysis which systematically looked at the articles published. It had a very wide-reaching audience. It was actually global. So based on her analysis, most of it was positive, but there were some negatives as well. So you can see alcohol guidelines misleading, better make a double, a scorching new critique of Canada's pseudoscientific alcohol guidelines, and so on. So you have all these articles that are very critical of the guidelines. And I want to get into a little bit of the misconceptions now, and it's very important to talk about, but I also want to get into some other things that are misconceptions as well. Next slide. And so there's also some misconceptions on what is peer-reviewed research and what isn't. So I want to single out this one just because there would be a question about why haven't we responded to it, or has it been responded to? So the International Scientific Forum on Alcohol Research, although a forum, is more of an industry-sponsored blog post than a peer-reviewed journal. It's not something that we can submit an article to and refute and have open and transparent peer review to. So Tim Stockwell and his group has taken it upon themselves to address the critique that they published on their website, which is sponsored by Alcohol Industry, in a peer-reviewed journal. So this criticism, and I just want to summarize it, wasn't unique. They took the limitations report from the guidance. They removed the context of those limitations, and they published them presenting like it was their own critiques that they found within the guidelines. That's not true. If you read through their critiques, they didn't properly cite our guidance and our limitation section. It isn't their own unique ideas. They copy us in our limitation section, took out the impact of those limitations on the guidance, and presented it as their own. I'm not going to get into the moral implications of that, but overall, all science has limitations, and we were very open and transparent on the limitations of the guidance. Overall, the main limitations of the guidance were that we were not able to include causes of disease that are causally related to alcohol use due to the problems with reverse causality. And that has to do mainly with depression. We weren't able to model the impact of alcohol use on depression because depression also leads to an increase in alcohol use. And therefore, we excluded it from our analysis. Otherwise, we've been very open and transparent with all the limitations. And that's something to be transparent about. And there will be an article that does address all these limitations that was published in this by this group. Next page. So what has been the actual reactions in the peer-reviewed literature, which is always very important? Well, CMAJ independently assessed the guidelines and found out that, yes, the information that we're providing is credible, systematic, and comprehensive. And the message that less is better is a scientifically founded, based in scientific evidence in terms of alcohol's impact on health. So CMAJ independently assessed the guidelines and came to the same conclusion as we did. Next page. So one of the problems that we face as scientists is that we get our message out through the media. That involves two steps. One, we have to communicate in lay language to journalists what the guidelines are and what they aren't. And that can sometimes lead to problems in terms of us taking our evidence that we're producing in more of a scientific, rigorous language and putting it into lay language. So that's one of the problems. The second problem is that the media is also biased towards the sensationalization of news. A lot of the statements that the guidelines are recommending people consume 2 or fewer drinks per day are flat out wrong. or sorry, 2 or fewer drinks per week, 6 or fewer drinks per week. That's wrong. The guidelines are informing people about their risks, not recommending any actual amount of alcohol use. There's also a problem with some media outlets having an ideological bias. We experienced this when trying to write, and other people that we know tried to write opinion pieces that were trying to correct some of the misinformation out there that were published in certain journals and papers. They didn't even hear back from these. And the media ideological biases are well documented, and I'm not going to get into that here. You also have media outlets not being peer-reviewed journals and not going through the same rigorous validation process that peer-reviewed research does. So there can be a problem there. You also have journalists not being scientific experts and are required to write about a lot of topics in a very fast time. So errors can occur. And then lastly, media publications are not open scientific forums, and responses to opinions are not always published or even welcomed. And we certainly experienced that when trying to communicate the guidelines as well, because there was a lot of misinformation out there we wanted to correct. Unfortunately, a lot of publications were not receptive to any efforts that we had to clarify any of these misconceptions. Next point. Next slide. So overall, I want to direct my attention to a couple of the media critiques and how we've dealt with them. So firstly, are the guidelines pseudoscientific? Did we go out and use an unscientific method or a non-validated method to create the guidelines? Absolutely not. We adhered to a strict standardized scientific protocol. This protocol is the grade adultment approach. It's not created or only used by us. It's used across the board, across multiple countries globally, and by multiple organizations. So you have the Canadian Association of Radiologists, the Canadian Task Force on Preventative Healthcare, the World Health Organization. Almost all guidelines use the grade adultment approach, and it's a very strict approach to formulating guidelines. So we scientifically adhered to the standard scientific protocol to develop these guidelines. Next slide. So the next point I want to get into is that we have had the accusation that we've amalgamated selected studies of low scientific validity that fit preconceived notions and ignored many high-quality studies whose results are not supporting of their own views. This is completely false. Again, we use a really scientific method to evaluate and include articles. So when we're modeling the impact of alcohol on health, we use what are called relative risk functions. So they model how much alcohol impacts health. To do so, we need to pick one relative risk function. There are multiple systematic reviews out there that present relative risk functions, and those relative risk functions are an amalgamation of multiple underlying studies. Now, the question is, how do we pick that systematic review? Was it our preconceived notions that we picked it upon? It's like, no, we had a standardized protocol. It was the AmStar. This is a standard tool used to assess systematic reviews. Again, this is a way of developing guidelines that is standardized and scientific. We're not selecting anything that we favor. It's based on what is the best quality systematic review according to the AmStar, a tool that's validated for assessing systematic reviews. Next slide. So another thing I want to get into as well is what were the results based on? So we have these results. They're pretty shocking. They deviate from the previous guidelines. And why is that? It's like, well, some people said, oh, you only use 16 studies. Now, this is highly misleading and really not considering all of the evidence. So the results are based on 16 systematic reviews. Now, I'm going to talk about the chronic diseases here because this has been published in peer-reviewed literature or systematic review. The systematic review of systematic reviews, it resulted in the inclusion of 16 systematic reviews, 14 of which were for chronic diseases. Among the chronic disease ones, this is 364 studies. 208 cohort studies, 155 case control studies. A lot of these cohort studies have tens of thousands of individuals in them, from all around the world, including Canada. This is not based on 16 individual studies. It's based on numerous studies, hundreds of studies. And so there was a problem with that in terms of the miscommunication of, well, is it 16 studies or is it hundreds of studies? Well, it's 16 systematic reviews, which summarize the evidence from 364 studies. So it's very important to keep that in mind. Next slide. And here's just a breakdown of it. So you can see that if we go through all of these different systematic reviews, we can see that you have a lot of different studies underlying each and every disease condition. Now, there are some that, like tuberculosis, that there have been very few studies published on the topic. There have only been 4 studies, but those 4 studies are for tuberculosis, same with lower respiratory infection. And then for other diseases, you have more studies published. Now, 4 studies for tuberculosis is quite low, and that identifies an area where alcohol research could improve upon. But we're limited by the evidence published at the time. We're transparent on how many studies were included in the analysis. We're transparent about the quality of those systematic reviews, and we document everything. And so overall, it's based on quite a few studies with quite a lot of evidence summarized across these studies. Next slide. So another thing that was highlighted in media reports in terms of like how we dealt with it was, do the guidelines account for confounding factors? And there were accusations that the underlying relative risks that we're presenting and that were used in the modeling only corrected for age and sex. That I don't know where people got it from, but I guess they thought that this was the case. It was a misinterpretation. All systematic reviews corrected for competing risk factors. So the guidelines did correct for confounding factors. This includes smoking, BMI, but the confounding factors do depend on the study and outcome. So there is heterogeneity in that. So next slide, and I just want to give an example of this. So if we're looking at tuberculosis, we have, these 3 studies that I just want to highlight because there's multiple pages, but you can see that there are many different variables that are controlled for. Now, some studies are more robust than others, but generally they have to have a minimum set of confounders that they adjust for when we produce these relative risk estimates. So these relative risk estimates are definitely adjusting for multiple confounders. Next slide. So the guidelines are based on relative risk and not absolute risk. And that's a common misconception. And I'm not quite sure where this comes from. We do present relative risks. We also do present the absolute risks. But this is false. The guidelines are 100% by definition based on your absolute risk of dying early because of alcohol. So the counterfactual would be, if you didn't drink alcohol, you wouldn't have died at that point. So what are the guidelines based on? What's the absolute risk? Well, it's based on the absolute risk of a person losing 0.0175 years of life lost, which is under low risk to moderate risk, and the absolute risk of losing 0.175 years of life lost, which is defines the boundary between moderate and high risk. And these risk definitions aren't our definitions. These are the definitions of the Canadian government, as well as set out by the British Medical Journal. So these correspond to 17.5 years of life lost per 1,000 people and 17.5 years of life lost per 100 people, or 1 death per 100 people and 1 death per 1,000 people. We use years of life lost to account for some deaths occur among 20-year-olds, some deaths occur among 80-year-olds. We have to standardize those deaths somehow to compare them, and we use years of life lost. Of course, if you die at 20, a lot of years of life lost. If you die at 80, very few years of life lost. But overall, it's your absolute risk of losing a certain number of years of life lost because you're dying prematurely of alcohol, not relative risk. We present the relative risks in the report of each disease, but that is not what the guidelines are based upon. Next slide. So how should I interpret years of life lost? This is another problem that we've run into. And admittedly, this is our fault because we haven't communicated them well or given information on how to communicate that. So 17.5 years of life lost, that's really difficult to interpret per 1,000 people. Let's just use the example. Does this mean that everybody loses 6.4 days of life that drinks this amount? And the answer to that is no. Those 17.5 years of life lost are not shared among everybody. The good way of interpreting that, so 17.5 years of life lost per 1,000 people, is you have a 1 in 1,000 chance of dying early from alcohol at this consumption level. That death will occur on average 17.5 years earlier than the age you would have died at if that alcohol attributable death did not occur. Some people will die at 80, some people will die at 20, but on average, it'll be 17.5 years of life lost. So that's how it should be properly interpreted. We don't have 1,000 people losing 6.4 days of life. We have one person in 1,000 years losing on average 17.5 years of life. Next slide. The next thing I just want to address very quickly is, why are you telling Canadians to drink less than 2 drinks per week? We actually don't make recommendations on an alcohol consumption amount. We are conveying risk, and we encourage people to reflect upon their risk. People's risk tolerances differ. We understand that. The risk tolerance of an individual may differ from another, and we're using standard language for these risks. These risks are calculated using the best evidence, using a rigorous scientific framework. But that risk may not be, a person's risk tolerance may not be another's, and we understand that. And we're just conveying that risk, and it's up to the person who is getting that information to interpret that risk in terms of, is this a risk I do want to take on in my life? Next slide. Another thing is, I want to go through what are the guidelines and what they are not, because there's a bit a miscommunication here. The guidelines do not provide advice to a specific Canadian. So they are not providing guidelines to me as a white male, 37 years of age, various risk factors, living in a middle income neighborhood. That is not specific to me. What the guidelines do provide is advice to all Canadians. They're guidelines for Canadians. Now, this means that this is based on the general population of Canada. This includes poor people, homeless, and people who have a lot of other risk factors. So hepatitis A, B, C, obesity, high blood pressure, smoking, etc. So these are not just Canadians who are middle-class Canadians. This includes all Canadians. And this is really important, especially when we get into those lower amounts. And I'm going to show you why, when we provide advice to all Canadians, that those lower amounts of consumption start to matter a little bit more than if you're providing advice to specific Canadians, especially middle-class people, without other risk factors. Next slide. So here's where it matters. We have this relative risk curve. And let's say this is liver cirrhosis. Cancer is a little bit different. Everyone's at risk for cancer. It will be driven, even at low relative risk amounts, by the general population, even if you don't have other risk factors. Alcohol can still cause cancer. But let's say we have liver cirrhosis. If you have 1 drink a day, are you going to develop liver cirrhosis? The answer to that is, what are your other risk factors? Because 1 drink a day alone won't cause liver cirrhosis. But if you have other risk factors, so moderate and high risk factors, which would put you in a different risk profile, you are going to develop liver cirrhosis and you are potentially going to die from liver cirrhosis. For example, we know from scientific evidence that people who drink very, very little alcohol but have a hepatitis infection are at a very increased risk of dying from alcohol use. We have people in Canada with hepatitis infections. That is just the reality of the situation. Therefore, our guidance is for the general population. And yes, one drink a day for some people in Canada in the general population may cause death from liver cirrhosis or a person to develop liver cirrhosis because they have other risk factors that are contributing to that liver cirrhosis. Next slide. So another thing that I want to highlight, because people have been picking out these small things like pharyngeal cancers and tuberculosis, which are quite rare. So I want to go on about tuberculosis a little bit, because this is an area that I think is needed in terms of clarifying what it means by causality and what we mean by burden. So alcohol use is causally related to tuberculosis. Does it cause the infection? No. Alcohol use does not cause the infection, but it's causally linked to TB infections. What do we mean by that? Alcohol has been causally shown to weaken the immune system. This weakened immune system leads to an increased risk of TB infection. Therefore, under the World Health Organization's definition of causal, if a person consumes a certain amount of alcohol, they are more likely to become infected with TB. So counterfactually, if that person didn't consume alcohol, that TB infection wouldn't have occurred in some cases. That's what the WHO means by causality. Causality in this definition was always set by the World Health Organization. This is a standard of causality in public health. It's used around the world by all public health organizations. We did not establish the definition of causality or even assess whether or not alcohol was linked to certain diseases. That is done by the World Health Organization and not by the authors of the guidelines. Therefore, alcohol does meet the causal definition when we talk about TB infections. It's not that alcohol is causing the TB infection, it's weakening the immune system, making it more likely that you will be infected by a TB. Number two, we performed a systematic and comprehensive analysis. Why did we include TB? Because it's causally related with alcohol. We are only counting diseases and conditions that are causally related to alcohol. We are not including things that aren't causally related to alcohol. That would include things like lung cancer. Alcohol is associated with lung cancer, but that's mainly thought to be due to the confounding effects between alcohol and tobacco smoke. There is some evidence that alcohol may cause lung cancer. If you take a breathalyzer, you can see that you are getting a positive BAC reading from that. And there could be a potential biological mechanism for how alcohol causes lung cancer. But current causal evidence between alcohol and lung cancer, it's not sufficient. But current causal evidence with alcohol and tuberculosis is sufficient. We want to be systematic and comprehensive. These are two very important scientific principles when we're performing analyses. Therefore, even tuberculosis, even pharyngeal cancer, we need to include them because we are being comprehensive and systematic. And then lastly, I just want to talk about the burden of TB and what is and isn't included. So in 2020 in Canada, there were 1,700 cases of tuberculosis. That's not captured in the guidelines, nor is the cost and resources to treat and to stop the further spread of TB. TB costs the Canadian government quite a bit of money each year. And in terms of the public health resources, it's quite intensive. So it's something to consider as well when we see things, media reports diminishing the importance of tuberculosis. It's definitely an important infectious disease. Next slide. So how are the risk thresholds determined? This would be, how are we defining our definitions of low, moderate, and high risk? Are we ourselves coming up with that? I've previously stated, no. These are based on strict governmental, environmental, and BMJ recommendations on how to define risk. These are definitions of risk that are standardized and are used for other risk factors. We're not creating language here. We're using standardized risk language. Next slide. This just gives an overview of how different frameworks define risk. Another thing I'll note here is that other low-risk drinking guidelines have defined low risk as 1 in 100 lifetime deaths. This is incorrect in terms of what they're doing. 1 in 100 lifetime deaths is found nowhere else in the peer-reviewed literature to mean low risk, except within guidelines for alcohol previously. And so to standardize across all risk factors, we determined to standardize our risk not based on what other people were doing with alcohol low risk drinking guidelines, but what the Canadian government is doing and what the World Health Organization and other governments are doing for all risk factors. Next slide. So part of the drama with the media came out with, why are these guidelines so different than other guidelines? So what we have to do is we have to standardize the risk levels, which I'm going to use 1 in 100 lifetime deaths. That would be the definition between moderate and high risk. But we can see that if you look at Canada, Australia, and the UK, they're fairly similar in terms of what their recommendations are. They're not different. Those would be well within the confidence intervals of our analyses. I don't see a large difference between Canada, Australia, and the UK. Of course, there are differences there. People in Australia, the UK, and Canada die of different causes. We tend to drink in different patterns. And all that is taken in consideration when we're formulating these guidelines. The next is the US dietary guidelines. These are often miscited. The 28 grams or less per day for men and 14 grams or less per day for women. So that would be 2 drinks for men and 1 drink for women, aren't on all days. They're on days when alcohol is consumed. And no risk level is used for those. But more importantly is on days when alcohol is consumed. That is not comparable to the Canadian, Australian, and UK guidelines. And therefore, it shouldn't be compared, because it's about that. The US dietary guidelines is about per occasion consumption. And if you look at our guidelines, we recommend people don't consume any more than 2 drinks on an occasion. That's 28 grams or less for men and women. So the US guidelines are actually more strict than our guidelines. Next slide. So overall, what are the conclusions from what I've presented today? Well, firstly, the Canadian guidelines are based on scientific, systematic, and comprehensive tools used for setting guidelines in Canada and around the world. We did not develop the methods to set these guidelines. We are using existing validated methods used to set other guidelines around the world. The guidelines do not make recommendations about alcohol use levels per week. They do make recommendations about per occasion consumption and who should not consume alcohol, but mainly when it comes to those risk zones, they convey risk and promote reflection. They do not recommend an alcohol use amount. The definition of low, moderate, and high risk, lastly, is based on a standard definition used in the scientific literature. This risk level reflects a standard set of definitions. We understand that a person's definition of low, moderate, and high risk may differ from these standard definitions, but we need to use a standardized definition and language when we're talking in scientific literature and producing reports, and that's what we did. But a person's acceptance of those risks also may differ. And so that's it.
So I guess I can go next. Thanks, Kevin. And hello, everyone. I hope you can hear me okay. As a new member of this community and as a newer member of CCSA, I would like to say thank you for the opportunity today to be here and be able to share some high-level information about CCSA's approach to knowledge mobilization for Canada's guidance on alcohol and health. having some issues with advancing the slides. There we go. Sorry about that. I hope it works better as we continue. Before I proceed, I would like to take a moment to respectfully acknowledge that the CCSA team today is joining from Ottawa, which is the traditional unceded and unsurrendered territory of the Algonquin Anishinaabe people who have been present on this land and its stewards since time immemorial. And in the spirit of reconciliation with First Nations, Métis, and Inuit peoples in Canada, CCSA is committed to contributing to making positive changes in our relationship with Indigenous peoples, and is committed to honoring the Truth and Reconciliation Commission calls to action and the United Nations Declaration for the Rights of Indigenous Peoples. So I think we can all agree that the release of the guidance in January of this year has sparked a national conversation around alcohol use. We have seen a heightened media attention for the guidance, which has also led to increased awareness for this work. And what we hope to do today with this event and this presentation is to also highlight the work that's taking place to support the understanding and the use of the guidance. So for the next few minutes, I would like to highlight some of the aspects of our knowledge mobilization efforts that include engagement and collaboration with different partners, publications of the scientific components of the guidance, taking a closer look at the media response, as well as monitoring and evaluation activities related to the awareness and use of the guidance. I would like to take a few minutes to provide a quick overview of available resources, as well as resources that are currently planned and underway. And I also wanted to take this opportunity to say that your feedback is very valuable to us. We know that it can steer our efforts towards the right direction. And I would like to say thank you for any questions that you are sharing. We have seen the questions you shared before the event today, and I hope we have some time to discuss any other questions during the discussion part after the presentations. Also, I wanted to say that the work I am presenting today represents the work of a number of people, including my colleague in knowledge mobilization, Bryce Parker. I know some of you know Bryce, and he will be moderating the Q&A at the end of the presentations. Christine, Wendy, Jill, Nolan, and of course, Dr. Catherine Paradis, who is not currently with CCSA, but has contributed enormously in every aspect of this work. And I would like to acknowledge the co-presenters, Dr. Kevin Shield and Dr. Peter Batt, for all the work that they have been doing and keep doing with the guidance. So we're now at about 9 months after the release of the guidance, and CCSA's main focus is to work and connect with different partners in Canada to improve the understanding and awareness of the guidance, but also answer questions that are most important to communities. And our goal is to support different groups in Canada to use the guidance, but also be able to adapt and tailor the information from the guidance to develop resources that are specific to their community needs, interests, and priorities. So over the past few months, in that context, our team has been focusing on some aspects that include gaining a better understanding of the current landscape of the knowledge and use of the guidance across the country, reestablishing and strengthening relationships with existing partners and collaborators, and expanding our network of partners, building on existing available information and resources to develop additional and more targeted tools, and also responding to incoming requests and supporting others to use the guidance. And on that point, the last point, I just wanted to say that we do receive many requests daily, either directly to one of us. We have an email address, which is alcohol@ccsa.ca, and we also receive many requests for copyright permissions for the tools that we have available. And this is important to us because it helps us to map out the different groups who are interested in our work across the country, the different requests, the needs and priorities from different regions across the country. This is a little bit dated. This does not reflect the numbers, but I just wanted to highlight that it's important for us to get a picture of what's happening across the country when it comes to interest for the guidance and how people are using the information. But the core of the work that we are doing is really engagement and collaboration. And CCSA wants to connect and work with as many national and regional partners as possible. And here we are including a list of partners. It's not exhaustive, it's just examples. And it includes people with diverse experience with alcohol, partners with in healthcare, public health, education, policymaking, and Indigenous partners. Now, in terms of the national partnerships, here I just include very few examples of some ongoing engagement and collaboration. I wanted to highlight our collaboration with the Canadian Institute for Substance Use Research. The team is working on developing a web app that's based on the guidance, and it can support people to understand and monitor the alcohol use. And also for those who are interested, the web app will be able to provide a more personalized risk assessment and also information about benefits that relate to reducing alcohol consumption. And this work is funded by Health Canada. CCSA wants to work with national partners and support the work that they do. And we know that there is great work happening across the country. And we want to be a convener of our partners in relevant national events. We want to facilitate collaborations and exchange of resources that are already developed in different regions. Now, recognizing that the regional alcohol landscape in Canada is quite variable, one significant component of our knowledge mobilization efforts is regional partnerships. And currently, we are engaging with Atlantic partners to gain a better understanding of regional efforts underway, the decision-making and service landscape, any campaigns that are happening. And we would like to identify how CCSA can best support these efforts. We are planning regional roundtables with wide representation from various groups, including community voices. And our goal is to identify regional priorities and priority populations, as well as champions that potentially we can work together to co-develop regionally specific strategies, tools, and activities. And I wanted to say here that I am mentioning Atlantic Canada, but this approach will roll out to other regions in Canada as well. And this is something currently in progress. We also aim to engage in meaningful partnerships with First Nations, Métis, and Inuit people and relevant organizations at the national and regional levels. We would like to gain a better understanding of how the guidance can support the communities and how we can support Indigenous partners to use the information, tailor the information, and create relevant, appropriate, and tailored messaging that reflects Indigenous realities. Over the past few weeks, we had the opportunity to share our work with groups that provide care to Indigenous communities. And right now we are exploring next steps in this engagement. And as we are doing all this engagement work, our research colleagues are focusing on publishing work from the guidance to peer-reviewed journals to share with the scientific community. So here you see 2 published manuscripts, and also we have 2 more in progress. One is going to discuss the methods used in the development of the guidance, and the other one is discussing the results from the first survey that's assessing how knowing the health impacts of alcohol use influence individuals' motivation to change their drinking behaviors. And of course, we have talked a lot about media coverage, and as Kevin mentioned, that prompted us to do a more in-depth look and analysis of the content of the media coverage. So currently we're doing a thematic analysis of the content, and we will compile a report and publish. It will be discussing the media context and experiences related to the alcohol guidance. And we hope that this information can help others who are doing similar work, as well as those in the international community. And in parallel, awareness and use of the guidance is also being monitored and evaluated. And this is work that will unfold over a period of 2 years. We already had 2 surveys that are out. The first round is complete. The second round is currently active as of October 20th. And the first round focus more on awareness and knowledge of the guidance, and the subsequent rounds will have components of assessing the use and the impact of the guidance as well. And for us, this is another source to inform our future knowledge mobilization activities. And now I think we are at the most fun part of the work, which is the resources. And for those ones who are not aware, CCSA has developed some foundational resources based on the guidance. You can find them on our webpage. Here I have a screenshot of the page. You can find them under the tab Communications Toolkit, and I also have the address. And you can find printable key message posters, social media assets, key messages presentation, and some other resources, including frequently asked questions. And we encourage everyone to access these resources and use them. I wanted to highlight a couple of tools that have been updated. So we now have a brochure with key messages. And I know this is something that many people had requested over the past few months. So now this is available on our webpage. And we also have updated the Knowing Your Limits with Alcohol guide that was there before, reflecting the old guidelines, but now it has been updated with the new guidance. And we do have a few other resources in progress that are targeting health professionals and journalists. We are updating an online quiz that we hope to be ready before the holidays. And of course, as you can imagine, we're having discussions about how to best convey the message about standard drinks. And we're very excited, of course, about the launch of our campaign. I hope that a lot of you had the opportunity to see it. It's based on the simple message, drink less, live more, and the sub-message, any reduction in alcohol use has benefits. The campaign started the week of October 9th. It's available in English and French, and it will run for about 5 weeks. I think the last day is November 10th. As you see, it uses bright, playful images to show and prompt people to think what they could be enjoying more in life if they were to drink less. The goals of this campaign are to create public awareness of the guidance and spark discussions amongst people in Canada. Also to build an understanding of the main takeaway of the guidance, which is drinking less is better, and to also correct the 2 drink per week limit misinformation. We have received very positive feedback on this work, and we are receiving requests from other groups across the country to support amplifying and disseminating this messaging. And the ads, when they're clicked, they take us to a new microsite that CCSA has developed, drinklesslivemore.ca. There you can find resources related to the guidance and also endorsements from partners across the country. In conclusion, I would like to say that this work is only in year 1 of what we think will be multi-year efforts for knowledge mobilization of the guidance. We do have various collaborations that are currently in progress and planning stages. For example, we do have an accredited event that's coming up in December for medical faculty members. And in this work, CCSA aims to lead, but also support effectively activities from other groups across the country. As I mentioned, we do know that there's a lot happening and a lot of great work, so we would like to avoid duplication of efforts. And again, as I mentioned earlier, this is the right time to provide feedback to guide this work further. And we will be happy to connect again with any updates in the near future. Thank you.
Thank you so very, very much, Effie. I may have problems with my feed at times. If it starts to flicker, I'll simply turn it off and reboot it. But that was great, good information. And I hope people in the audience are taking the time to put questions into the chat feature or to make them available when Bryce begins to moderate that. So what I want to do now is to pivot towards the clinical implications of our guidance on alcohol and health. Next slide, please. So the overarching recommendation is very, very basic. It's to reduce the risk of harm from alcohol. So we recommend for people living in Canada to consider reducing their alcohol use. So this is it, folks. It's simply about encouraging people to reduce their alcohol use. And how we then go about it is the art. Next piece, please. We have the continuum of risk that's been very well defined scientifically. Kevin has gone through that, and it's all the way from 0 to increasingly high risk, recognizing that people are going to be in different categories. Currently within Canada, amongst those who drink, approximately 50% are at the 6 standard drinks per week level or lower by self-report. So I think that what this means is that half the population, if we exclude the people that are abstaining, are already at those low to moderate risk levels. And we perhaps need to be thinking about those that are at the increasingly high risk and consider how we might engage them in a reduction. Next slide. So this comes about through helping them to individualize their risk. We have this population health-based diet. Now it's a question of promoting reflection on the risk from alcohol use that they alone have. So do they have a personal or family history of an alcohol attributable condition that would trigger us to encourage them to reduce their level of consumption even further, or possibly even consider abstinence, depending upon their level of risk and their risk tolerance. Next slide. So these charts are hopefully going to be very helpful. This is increased risk for females as an example of the clinical implications. Across the top, what you see are grams of alcohol per day. So at 13.45 grams, one standard drink per day would be between 10 and 15 if you draw a line vertically there. And based upon the modeling with regards to cardiovascular disease specifically, what you see is increasing risk for most cardiac conditions, even at that one standard drink per day level. You see a slight reduction in terms of ischemic heart disease and ischemic stroke, but it doesn't reach the level of being able to recommend it as protective. Mildly protective, if we use a conservative approach, the best we can say is that it's neutral with regards to consuming alcohol and the risk of ischemic heart disease and stroke. But when you consider the rest of the cardiovascular system, the rest of the heart, overall, not even taking into consideration cancer and liver disease, overall, alcohol is not good for the heart. With regards to cirrhosis, again, this is based upon the modeling. So if there are cofactors, as Kevin described, then certainly risk increases even with very low levels of alcohol consumption on a regular basis for women. And then when it comes to breast cancer, colorectal cancer, liver cancer, esophageal, oropharyngeal, laryngeal cancer, the 7 cancers that are identified as causally associated with beverage alcohol, again, increasing risk even at that one standard drink per day. Next slide. This is somewhat similar, although the risk profile is a little bit different for males compared to females. You certainly see the increase with regards to cardiovascular disease, including hypertension. Not as profound as for women with regards to liver cirrhosis because of the physiological differences in metabolizing alcohol. However, it's certainly there. And we have, of course, removed breast cancer because of its low incidence. And these other 6 cancers men are definitely vulnerable to with regards to alcohol use. And keep in mind that this is something that people need to look very closely at in terms of their family history as well, to see if there's any genetic indicators of elevated risk that they need to be more mindful of in addition to their alcohol use. Next slide. The World Heart Federation has contributed to debunking the mythology with regards to alcohol and heart health, and has simply said, contrary to popular opinion, alcohol is not good for the heart, and risks due to alcohol consumption increase for all major cardiovascular diseases, including hypertensive heart disease, cardiomyopathy, atrial fibrillation, and flutter, and stroke. And this is information that we need to get out to, indeed, not only primary healthcare providers, but also cardiologists themselves. We need more support in helping to debunk the mythology around this, which was conflated with the Mediterranean diet. Next slide. With regards to cancer causation, alcohol is a group 1 carcinogen. And what that means is that it's met 3 different criteria. We've been able to demonstrate cellular impact with regards to the oncogenic mechanism of alcohol in different tissue types. Secondly, we have animal models that reproduce that mechanism. And thirdly, we have the epidemiological data within human populations that establishes that association. So group 1 carcinogen, well known, it's been well known for decades. And yet here we have a beverage intended to be consumed that's a group 1 carcinogen with absolutely no warning label on it. Next slide. When we go into more depth with regards to alcohol attributable cancer deaths, what you see on the right are the percentages of those 7 cancers that are alcohol attributable. So close to a third, if not more, in terms of the upper GI tract are associated with alcohol. Liver cancer, 20%, laryngeal, 22%, colorectal and breast, 11 and 7, respectively. Now, keep in mind that if we were to look at the actual incidence, it would be somewhat different. The graph would be sloped the other way because the incidence of colorectal and breast cancer is much, much higher in the population. So the number of people impacted would be much greater, despite the fact that the alcohol attributable portion is lower. The upper GI tract is cancers are not nearly as common, but the percentage attributable to alcohol is certainly high, as we see here. Next slide. So we need to help people to reflect on their risk, situate themselves within this continuum, and then clinically provide them with guidance to help them to reduce, to set a goal and help them to achieve that. Next slide. So clinically, we need to be thinking about a triaged approach to goal setting, recognizing first and foremost that individual risk comfort is variable and not necessarily grounded in acute personal or actual personal risk. In this sort of situation, you may be thinking of somebody who's quite concerned about developing breast cancer, even though they have no family history of breast cancer and no personal history of breast cancer. They may be wanting to reduce simply to prophylactically to prevent it. Whereas we might be thinking of somebody who has hypertension, is on medication for hypertension, but really is not so inclined to reduce their alcohol consumption because it's under control. They don't feel that it's so threatening to them. They can tolerate the risk at a higher level. So we very much have to work with people starting where they're at. So in general, however, we want to encourage people to reduce. Less is better, with a potential goal of 6 standard drinks per week or less. So we would like to see the population getting down to that moderate risk zone or lower across the board. If they have increased personal risk of an alcohol attributable condition because of their own history, for instance, or that within their family, then it would be reasonable for them to get down to that low risk category of 2 standard drinks per week or less. If they actually have a presence of an alcohol attributable or exacerbated condition, people should be encouraged to consider 0. If they have liver cirrhosis, perhaps due to hepatitis C that's definitely is being exacerbated by alcohol consumption, then of course we're going to recommend, both in the situation of the liver disease and the co-occurrence of alcohol and hepatitis C, that they abstain. So this is something where goal setting needs to be done collegially. It needs to be done in a way that makes sense to individuals, so we can explain why this would be important. The charts that I showed you previously, the very colorful charts, show just a few of the alcohol attributable conditions. These are opportunities for primary healthcare providers and others to have this conversation around alcohol and health, not necessarily talking about whether or not there's the presence of an alcohol use disorder, although there will be times when it's important to screen for that and treat it, but rather to talk about the impact of alcohol on health more broadly and engage people in conversations, raise the level of alcohol literacy, and thereby help to reduce consumption and improve health and well-being of the population. Next slide. So, of course, we need to start where people are at, use a stage of change approach, motivational interviewing. I've already commented on how some people are going to be more or less risk tolerant, and further along in terms of planning or action based on that. Next slide. It helps when you're doing motivational interviewing, of course, to understand why people drink. And these are a couple of the categories in terms of personal effect motivation and social effect motivation that might be helpful to contextualize this and help to explore why people use. So personally, people may be doing it purely for the enjoyment. People use mood-altering substances to change the way they feel. Very common. To avoid boredom, to escape problems, or to get intoxicated. People are quite often quite frank about this. What's the point in drinking if one isn't getting intoxicated? On the other hand, there are social effect motivators, such as socializing, to celebrate special events. Alcohol frequently marks the end of a work day, the end of a work week, special events such as marriages, deaths, births, and so on. To increase power, and this may seem to be odd, but think about the drinking competitions on one hand, or so-called power lunches on the other, that are often alcohol fueled. And then the social ritual. The truth of the matter is that many people have both personal and social motivators. So it's a way of unpacking our relationship with beverage alcohol and helping people to think about it on one hand, prompt that reflection that we need, whilst at the same time thinking about alternative ways to achieve the same goal in a manner that's healthier. Next slide. We also need to be thinking about the benefits of alcohol reduction. This isn't just about taking something away from people that they feel is important to them and being a wet blanket, but rather providing very good concrete information with regards to the benefit of reduction, such as decreased calories and weight loss, improved sleep with more energy, improved cognition and memory, improved mood, decreased blood pressure, blood sugar, triglycerides, liver fat. These are all important measures. Also, we can be thinking of improved sex life, quite contrary to what the industry tends to promote. Improved immune function, and of course, that's a significant factor when it comes to the risk of tuberculosis, for instance, as well as cancer. Decreased cancer risk, decreased risk of accidents and injuries, improved relationships, in part because of the improved quality of communication and being present and attentive, but also decreasing, particularly amongst males, the level of aggression and violence, and financial savings. Next slide. So harm reduction strategies are included in the knowledge mobilization information, such as choosing a target, choosing a goal, sticking to it. If people can't stick to their limits, then maybe they have more of a problem in their relationship with beverage alcohol than they appreciate it, because it's not whether or not they can abstain, it's what happens when they do drink. Is it out of control, and are they experiencing negative consequences? Encouraging people to drink more slowly, to take sips rather than shots. Drink lots of water. And certainly one way of encouraging this is to inform people that it does indeed reduce the hangover effect. So for every drink of alcohol, a person should have a non-alcoholic drink. They can alternate it back and forth. Nobody needs to know what's in their glass or container, how much they're drinking. That's really nobody's business. So people can alternate quite readily. Increasingly, some aspects of the industry have responded with more alcohol-free beverages or low alcohol beverages. And this gives consumers more choice. So they could have a 0.5 standard drink, beer, for instance, and thereby reduce the amount that they're consuming over the course of an event or an occasion. Eating before and whilst drinking slows the absorption of alcohol, which helps to avoid the acute intoxication. And also it increases the feeling of satiety. So they might no longer want to drink because, frankly, they're full. And finally, having alcohol-free days or weeks or alcohol-free activities is another way of introducing this change in people's lives. Next slide. So overall, the message is less is better, helping people in that increasingly high-risk zone to reduce by 2 or 4 standard drinks per week. Arguably, because of the exponential nature of the curve, is going to have an exponentially greater reduction in their health and well-being in terms of the reduction of risk and harm, and an increase in their health and well-being by reducing than somebody going from 6 to 4. So we need to celebrate this amongst all consumers and help them to reduce it. Again, hopefully in very pragmatic harm reduction strategies that are based in their risk profile and their concerns with regards to health and well-being. Next slide. And with that, I'd like to thank you very much, and I'll turn it over to Bryce to moderate questions.